Tēnā koutou, tēnā koutou, tēnā koutou katoa. It's great to be back in New Zealand. It's probably about my 8th or 9th trip now. And and thank you so much for Joanne for putting this on. So when I wrote briefly, I had the opportunity to touch base in New Zealand for a few days. You mobilized everything, so thank you to you and your team. And again, for our ongoing partnership, it's great. And I'll tell you why it's great. You asked me to reflect upon some of the issues about how we deal with vulnerable populations and some examples from Europe. We've been commissioned at our foundation to do some work with the network of European foundations. And this is on a project that's really looking at what they call integrated community care. And what they're interested in looking at is how we can take a place-based or neighborhood-based approach to support communities who are facing very difficult circumstances, particularly in managing vulnerable rural or remote populations. And what's interesting for me is you see two things. And we've been asked to do a mapping project, and I will be emailing you afterwards for lots of different ideas from the different things that are happening here, because I think they probably come across. But you find two things, and one is part of what we try to achieve at the foundation is to advance the science and understanding what integrated care means, and by any stretch, the sorts of key components that you just heard in the last presentation would be present within that group of issues that are necessary. But two things are often overlooked, and you go into the literature and you try to find some promising practices in this community-led approach, an assets-based approach in communities to improve people's lives, and it doesn't exist, or if it does exist, it's relatively few examples, particularly in the peer-reviewed literature. And it doesn't exist for a number of reasons. Firstly, the science is completely skewed to managing or to looking at issues related to chronic illness and frailty, and focusing in on those things that they can randomize against those things that they cannot. So the evidence itself doesn't produce you with enough information to understand what this kind of community-based approach requires in order to achieve better outcomes. And I think then, secondly, we, particularly in Northern Europe, but there are some really good examples otherwise, we live in a political situation where the voice of people is crowded out by the financial issues related to the management of your health and care system. So for example, in England, we've been on a journey, we like to change the way we do things every 2 or 3 years, but we're on a journey to create American-style accountable care organizations where you have place-based, geographical-based activities where GPs will become to work together in new provider organizations with social care and potentially also with hospitals to deliver population health management to these groups. These will be managed by large managed care organizations, I'm sure, rather than necessarily the NHS. In the plans, a really core component of those plans is that we're going to engage with the local community, both in terms of the governance level, so that we represent them within these bodies, but also we think that integrated care ought to be, they say patient, it should be person-centered and focused on the needs of that community. And that's what's going to underpin the way we think about the services that we're going to deliver. But when you look at the evaluations of these service transformation plans, STPs, you see, there's a lot of 3-letter acronyms, a lot of TLAs, 3-letter acronyms. Service transformation plans, at the beginning, they look absolutely fantastic, the way that they're described about how we're going to change the system so that we use an asset-based approach that enables health, social care, housing, I wish pharmacy was in there, not necessarily there, schools, community groups, leisure clubs, they will all come together to form a new approach that focuses more on public health and social determinants of health and try to move upstream in terms of our ability to support and manage particularly the most vulnerable within those communities with the purpose of promoting health but also with the ultimate purpose of making your system more sustainable financially, and also in terms of changing the utilization of expensive care facilities, whether that be in hospitals or nursing homes and other places. But you see the direction of travel over time, within 2 or 3 years. And fundamentally, the task for the chief executives or others involved in managing that process has shifted from one which is population health focused to one that is solely focused, depending on where you go, but politically is solely focused on being able to reduce your overhead from, say, spending $6 billion a year to $5 billion. And you've got to achieve that saving within 5 years. So it becomes a process of managing acute demand. This is about emergency admissions. This is about enabling a reduction in numbers of people who could have been managed in primary care but are not, focusing in on ambulatory sensitive conditions. This is about length of stay in hospital. This is about early discharges out into the community. This is fundamentally about managing acute demand and managing finances. And as soon as you get into that debate, the whole ethos of the community and the patient is crowded out of those conversations. And the gain that we made maybe 10 years ago through a group called National Voices, which is the patient representative group in the UK that gave voice to what integrated care meant, gets lost. And you see that time and time again, wherever you go in European healthcare systems, that actually the fundamental question is, do we believe that if we invest upstream, we can achieve a more sustainable health? Well, everybody says it's in every single strategy, but when it comes to delivery, we can't get away from the fact that we're managing money and resources, and that's the bottom line. So it's a real problem. So not only, but the problem also is, therefore, the manager comes to you and says, okay, clever son, you're integrated care, you tell me, what is the benefit of me being able to invest in this community approach that you're telling me is going to lead to a sustainable effort? Because I've got to turn around this health economy in 3 to 5 years. You tell me what the value case is. And nobody can answer that question. You've answered some of it here, actually, by the way, which is why it's really impressive. But most people can't answer that question. And therefore, no one's going to invest in it. And that, for me, is the real thing for me, as an advocate of integrated care, is how do I find the methodologies that enable us to develop the value case that's fundamentally going to shift the thinking that enables you to invest in those objectives. I think the second key concern that I see is probably also a more fundamental one, is that everybody understands that healthcare should be about patients and people and families, and that we should seek to coordinate care around their needs. No one's going to argue with that. But then when you get into those discussions, and I was working with the World Health Organization in developing some of their global strategy around this. And they were very keen on putting in person-centeredness. So it's not just about integrated care or population health, everything has to have person-centeredness in the title. And the thing is there, is that the vast majority of people take this paternalistic, I know you've probably been tackling this all of the time here, this paternalistic approach. You know, we will take into consideration the patient's views and then we'll do something to you. It's fundamentally not about co-design, about engagement, about shared decision making, about supported self-care, about medications management, about enabling independence in the home, about supporting all of those social care factors, which we know if you address those, enable people to live a more healthy, more active, more enabled life in their own communities that are not related to any sort of health intervention at all. And that's evidence-based. But when it comes to the decision makers, we have this paternalistic attitude, and that gets in the way, that's the second thing that gets in the way of this ability to really engage with communities effectively to help turn around care systems in difficult circumstances. And then you lead to the third observation, which is who are the groups who would most benefit from care coordination or integrated care who don't get it? These are the most vulnerable populations within our societies. We coordinate care very effectively for people with individual chronic illnesses or for other issues. We have tremendous care pathways for people with cancer. Where it's done well, we do rather good in end-of-life care, actually, which is a complex issue. So we can do it there. Why can't we do it for these other complex areas? So this is a really significant problem. And the people who most fall between the gaps, this is inverse care. The people who most fall gaps, these are people living in remote and rural conditions. These are people living in poverty. People living in communities that have generations of unemployment. People who have low educational attainment at school. So this is not, fundamentally, when you look at the pathology of the individuals who end up being the next emergency admission to a hospital, this is 90% of the problem. And yet we don't focus on that in a way that we should. So in my foundation, where we started out, 17 years ago, grey hair, it was about frailty. Some of it was about pediatrics. Most of it was about chronic illness care. We're trying to take this on a journey that focuses on, we're not going to solve the big issues of our day, the practical solutions to today's public health problems, without thinking differently about the way that we do things. So the relationship we have with Whanataki and some of the work that you've been doing is instructive internationally to enable that debate to be had, which is why I'm so pleased to be here. And it's a real challenge. But there are pockets of excellence, and Joanne, you challenged me, where would we go to see them? So I might give up 2 or 3 examples, and then we can finish up and take some questions or have a drink. So what have I been most impressed with recently? I suppose one of the ones I've been most impressed with, and it was runner-up in our awards when it was presented in Dublin. And it was led by a GP, and I'll tell you a little story about this GP. This is not your usual GP. He was working as a primary care doctor in Rwanda during the genocide, and he was able to bring something like 2,000 of these individuals, these families, and he was able to protect them within a football stadium, and he marched them out in front and managed to get them to a safe place and get them home, or get them to a safe location. So this is not your usual GP. So he ends up running a rural practice in a place called Millom, which is a kind of an isolated community of about 10,000 people, maybe slightly less, one small junior school, 15 pupils, that sort of place. And the local voluntary hospital closed overnight for financial issues, and the GP retired and handed in the keys, so there was no primary care service. So there's nothing here. What can we do? So he was able to mobilize the community in a way which was tremendously effective, through the schools, through the fire service, through the post service, finding ways in which they could connect older people more effectively together, not through health, but just through community support groups, to be able to manage frailty and to be able to manage health more effectively. And it's well worth going to have a look at, to the point that that really small little project, born out of a crisis, has now been taken up as a way of working across that whole community just north of Morecambe Bay. And I think that's really rather good. So that's one example of what you can achieve. And I wish these things didn't always have to be achieved out of a crisis, but most often they are, which is a shame. I suppose another good example is from Finland, and Finland is interesting. They're just going through a big reform process now where they want to create a new health or social care authority in government and rationalize the way they do things into 10 health and social care integrated organizations. Whereas previously they had something like 3,000 different municipalities who the mayor all had certain thing to say on whether I take forward integrated care or other issues or not. Well, in certain parts of Finland, as you might imagine, it's pretty rural and people are living on islands and living in isolated circumstances, and it can possibly take half a day to a day to get to a medical facility. So as the population began to get older, this was becoming a significant problem. So the district health board came together with the social care authorities and decided we need to do something about this and created an integrated authority. But fundamentally what they did was enter into strategic partnerships with each of these little municipalities in this region, with the mayors, with the community groups, particularly with the mothers, to be able to work through what is it that you require, what matters to you to enable you and to support you. So this wasn't about having medical facilities, this was fundamentally about reducing social isolation, having somebody to talk to. Just having security of mind that I'm taking my medications appropriately. So they used a whole range of different methods to do that, including municipality events when the healthcare team might be in town in order to support that kind of community engagement. The use of new technologies and telehealth so that people living in difficult circumstances didn't actually have to leave their house and spend so much time being able to have a consultation with a doctor. Having mobile units, extended ambulances look a bit like small buses, or even little water taxis that started to go round to these communities and they know when they're arriving. When I was growing up, it used to be the fishmonger would come from Grimsby on a Tuesday and the siren would go and everyone would run out to get their fresh fish because that was the only time you could get it. But this is the kind of thing, they're in town, what can we get? And they can get their bloods tested, they can get dental advice, a whole range of different things, just run by a social worker, a GP and a technician. And all of that data plugged in real time in an electronic health system available for use at the point of care. They achieved that in 3 or 4 years. And what were the outcomes? The best outcome, significant increase in mental health or mental well-being for people, a 50% reduction in unnecessary medication usage, significant savings because people are not having to travel ridiculous distances in order to find care, significant increases in quality of life. Are we seeing massive reductions in emergency admissions to hospital? Are we seeing reductions in length of stay? Do we see these other things that people so geared up about? It wasn't about that. It was fundamentally about something different. And that is a system that's stuck after being a pilot scheme, and it's there in that locality. Has that been rolled out anywhere else? No, because something about the culture of that community has enabled it to happen, and the vision and the commitment of people. So the other thing, and I'll finish with this, the other thing that I see is there are 3 issues, and I would say there would probably be 3 issues for New Zealand if I was to put my finger on it. One is I think probably we all know what integrated care means, and probably we all have versions of how it can be achieved. But I think there are 3 fundamental things. Is we don't necessarily know how to support the sustainability of those programs because they're using funny money or they're led by people who might only last 3 or 4 years in that position, whatever. So they're not sustainable. So therefore they don't get the spread and sustainability that happens. So spread and sustainability doesn't happen. And I think the other thing is they're not evaluated. And if you're not going to evaluate these new innovations, you're not going to be able to feed them into the business cases. And I'm not going to be able to put them in my journal to demonstrate to the world that some of these things really are important and mean things to people and generate the outcomes that you're looking for. So that was slightly off the cuff, but where you go and see these types of operations and they work, they're not just demonstrating really quite radical improvements in health in a relatively short period of time. They're also just tremendously uplifting because this is about the community, and when you talk to it, it's just a different conversation that you have. And they're really great to go and see those projects. So Joanne, thank you so much, and I'm very happy to take questions or conversations. It's fine.